part of the surgical webinar. We are updating about all the surgical conditions. Sasha is making an amazing job putting together all of these outstanding speakers, and we hope all of you can join and can learn more from all of them. As a keynote speaker, we are going to have Dr. Nikaido talking about the Nikaido procedure. And then on the next Friday, we are going to continue this morphological series of Dr. Anderson to talk about the double inlet ventricles. So now with you, we are going to start hypoplastic left heart syndrome with Dr. Anderson. Welcome all and please enjoy. Don't forget to place your questions on Q&A chat box and talk to us on the chat box. We really want to interact with all of you, and Dr. Anderson is here to answer all of our questions. Enjoy.
So what we are talking about, again, is hypoplastic ventricles. And what I'm going to be stressing again this week, we're looking at another instance where we're dealing with acquired diseases during fetal life. So let me remind you again, these acquired diseases can involve either the morphologically right or the morphologically left ventricle. Last week, we discussed pulmonary atresia with intact ventricular septum. This week, we're going to discuss the hypoplastic left heart syndrome. We don't need quite so much this week to distinguish between hypoplastic and incomplete ventricles, because in hypoplastic left heart syndrome, all the ventricles are hypoplastic and none of them are incomplete, because they all possess all three of their component parts. And what we're going to be discussing again is that the hypoplasia in this setting, rather than in the setting when the ventricles are incomplete, it is the hypoplasia, the size of the ventricle, that reflects the timing of the developmental insult. So once more, as with last week, we're looking at a spectrum of malformation. Last week, we discussed how, depending on the size of the hypoplastic ventricle, in some instances, you could opt for biventricular repair. In other instances, the only option was likely to be a functionally univentricular repair or transplantation. Almost always, in the setting of the hypoplastic left heart syndrome, we are talking about a functionally univentricular repair. And you all know as well as I do that the majority of patients who now come forward for conversion to the Fontan circulation are patients with hypoplastic left heart syndrome. But in a few instances, there are hearts in which it may be possible to achieve biventricular repair. So I'm going to discuss that with you also today. But let's start by asking the question, why do we call this entity hypoplastic left heart syndrome? And so we go back to 1958, Jackie Noonan and Dr. Nadis. Let me say just a few words, if I may, about Jackie Noonan, because she passed away relatively recently. She was a delightful lady. I knew her quite well. I made several visits to Lexington whilst she was chief of pediatrics. I gave the Noonan lecture in her honor after she had retired as the chairman of pediatrics. And in my recent visits to Lexington, she again attended my lectures, and she was a delightful lady. And together with Alex Nadis in 1958, they suggested that the hypoplastic left heart syndrome was a term coined by Maurice Lev, as you see, to describe the lesions we're going to discuss today with an obstructive lesion, atresia or stenosis, on the left side of the heart. In fact, if you look back at the work of Maurice Lev, when he was describing this spectrum of malformation, he called it hypoplasia of the aortic outflow tract complex. So in reality, it was Jackie herself who introduced the notion of the hypoplastic left heart syndrome. So we could argue that she has two syndromes that we should call Noonan's syndrome. Today, we're going to discuss the second, and we'll call it hypoplastic left heart syndrome. So the left ventricle can be hypoplastic and incomplete in the setting of univentricular connections with a dominant right ventricle. We're not going to be discussing that today because that is not what we call hypoplastic left heart syndrome. The left ventricle can also be hypoplastic when there's either a ventricular septal defect or an atrioventricular septal defect. And again, although some of those patients may come forward for functionally univentricular repair, we should not be considering those patients as having hypoplastic left heart syndrome. There is a specific diagnostic combination that produces the hypoplastic left heart syndrome, and that is the setting of concordant atrioventricular and ventricular arterial connections with an intact ventricular septum. And it is this feature that tells us that the insult stopping left ventricle from growing must have occurred after closure of the embryonic interventricular communication. And that is why, once more, we know it is an acquired disease of fetal life. And I cannot overstress this point. Hypoplastic left heart syndrome is an acquired disease of fetal life. But it isn't an entity in itself. It's not like tetralogy of Fallot, where we can define tetralogy on the basis of the phenotypic morphology. There are several phenotypes that we put together so as to make up the hypoplastic left heart syndrome. So we can find the syndrome when we have combined atresia, the mitral valve and the aortic valve. We can find lesion when the aortic outflow tract is atretic, but the mitral valve is stenotic, so that blood can go into the hypoplastic left ventricle. And that is an important feature I'm going to be emphasizing. But we can also have the hypoplastic left heart syndrome when we have combined mitral and aortic stenosis. And then you do have a problem as clinicians in determining which of these hearts are going to be suitable for functionally univentricular as opposed to functionally biventricular repair, because the spectrum here extends into critical aortic stenosis. But then there is a subset of these hearts with combined mitral aortic stenosis in which, as I will explain, the aortic and mitral valves are commensurate in size with the size of the left ventricle. The left ventricle is hypoplastic, and these are the hearts that Christo Chevenkov from Montreal described as the hypoplastic left heart complex. For quite some time, I was dubious about the existence of this entity, but as I will explain, I now think that Christo was correct and that these hearts do indeed exist, and we'll be discussing them as we move through this presentation. But let's start by looking at the worst end anatomically of the spectrum, those in which the mitral valve is atretic. And this can give the appearance of absence of the atrioventricular connection, although, as I'm going to show you, there is evidence that the left atrioventricular connection was initially present and became atretic. And there is ongoing evidence to show that this is a cascade because there are other hearts in which the mitral valve is obviously present and yet it is imperforate. So this is the situation in which the left atrioventricular connection, to all intents and purposes, is absent. There you see the fibroadipose tissue of the left atrioventricular groove that is interposing between the floor of the left atrium and the tiny left ventricle. The left ventricle in this setting is slit-like, but the key point, there is no fibroelastosis. And that is because the mitral valve is atretic. There is no blood going into this grossly hypoplastic left ventricle. Here is another very nice picture showing us the seeming absence of the left atrioventricular connection. And as so often now, I'm using Diane Spicer's beautiful photographs to illustrate the morphology. So here Diane has concentrated on the left atrioventricular junction. And again, you see the fibroadipose tissue that is interposing between the floor of the left atrium and the cavity of the left ventricle, which again is slit-like, and once more, no fibroelastosis. Now, a long time ago, the group from Leiden conducted some histologic examinations of these hearts when Arnold Weinig was working in Leiden, and they showed that if you trace the histologic sections, you could find evidence of a track between the floor of the left atrium and the top of that grossly hypoplastic left ventricle, indicating that at some point in time, there had been a left atrioventricular connection. Note in passing that in this heart, there is an intact atrial septum. It's bowing out into the right atrium, and we'll come back to that. But if we look at other examples in which there is seeming absence of the left atrioventricular connection, and here another of Diane's beautiful pictures looking down into the floor of the blind-ending left atrium, you see that there is evidence of a mitral vestibule that we can trace down towards that slit-like left ventricle. So almost certainly the connection had initially been present, but has been obliterated since the insult in this instance occurred very early during fetal development. And we can see the spectrum of malformation when we look at those in which the mitral atresia is due to an imperforate mitral valve. In this one, you see that there is still tension apparatus in the left ventricle, which is somewhat more globular, but it's still tiny. And again, there is no fibroelastosis. And yet a third example, this time from an explant, again, one of Diane's beautiful photographs. This time, the mitral valve is a little larger, showing that the insult happened later during fetal life. But again, the left ventricle is tiny. Look how close it is to the atrioventricular junction. Once more, without fibroelastosis, but with tension apparatus of the atretic mitral valve itself being imperforate. And we can find the cavity, this tiny cavity of this hypoplastic left ventricle, as you see here, in the hip pocket of the ventricular mass. And since the hearts have effectively concordant atrioventricular and ventricular arterial connections, we find it in the left hip pocket. So there again, you see the atretic mitral vestibule. There is the coronary circumflex artery running within the left atrioventricular junction. And there I have found this tiny cavity of the left ventricle without fibrosis by dissecting between the limiting coronary arteries. So that is how we find the tiny left ventricle when we have combined aortic and mitral atresia. So this is what we see when we look at the aortic part of this combination. The pulmonary trunk is coming out of the right ventricle. It's continuing via the arterial duct and feeding the descending aorta. The blood then comes retrogradely into the aortic arch. Then it comes back down through the thread-like ascending aorta and feeds the coronary arteries. And there you see the bulb of the ascending aorta with the tri-radiating sinuses showing us that the aortic valve also was present at some time but has become atretic, and it is feeding the right and the circumflex coronary arteries. You see in this instance, Diane has placed a marker at the top And look how tiny is this aortic root. And this is another of the features, the insult producing the cessation of growth of the left ventricle occurs at various times. The earlier in development the insult occurs, the smaller is the ascending aorta. So it's not unexpected to find the smallest aortas when we have combined aortic and mitral atresia. But let's move on, and let's now look at the next stage when development has progressed a little further. So the mitral valve has not become atretic or imperforate. Instead, it is stenotic. And that permits flow into the left ventricle. And that, I believe, is what provides the stimulus for the fibroelastotic lining that is the key to finding hearts with mitral stenosis. So here you see the typical feature, the olive stone left ventricle lined with fibroelastosis. You see that the mitral valve this time is stenotic, and it is the blood going into that left ventricle that stimulates, I believe, this development of the fibroelastotic lining, which also extends onto the tension apparatus of the mitral valve. And so now you see the apex forming right ventricle, which wraps itself around this left ventricle with a tiny cavity, but a grossly hypertrophied wall. We see it again here in the setting of aortic atresia. So this is the second combination, mitral stenosis, aortic atresia. But in all of these cases, with the stenotic mitral valve, because it's patent, the blood is able to get into the left ventricle, and hence we have the fibroelastotic lining. Again, in this example, you see the triradiating valvar sinuses telling us that at some stage there had been flow up into the aorta. And note that this time the aorta is a little bit larger, and I presume that is because the insult that stopped the left ventricle from growing happened a little later than when we have combined aortic and mitral atresia. But we can also have mitral stenosis with aortic stenosis. But again, you see the thick-walled left ventricle has its fibroelastotic lining. And there you see the patent but stenotic mitral valve. Now, because the aorta is stenotic, once more, I am presuming the insult was a little bit later in fetal life, and so the aorta is now that much larger. And then we get to that watershed between critical aortic stenosis and hypoplastic left heart syndrome. So in this instance, we have a unicuspid and unicommissural aortic valve. You can see the raphes that are separating two of the sinuses with the solitary commissure pointing back towards the mitral valve, which is patent but stenotic. And in this instance, the left ventricle is quite large, but it has its fibroelastotic lining. And for my money, despite the fact that we have the unicommissural and unicuspid aortic valve, I would put this firmly into the ballpark of the hypoplastic left heart syndrome, combined aortic and mitral stenosis. And now we have another problem that reflects the fibroelastosis, and that is fistulous communications. And they are found only in the presence of mitral stenosis. And the late Robert Freedom, another great friend of mine, passed on quite some time ago now, Robert always maintained that these fistulous communications blighted the myocardium. And he predicted that they might be a bad prognostic feature. In fact, we know that microscopic communications with the coronary arteries are ubiquitous. And this was more work that was done in Lexington under the guidance of Jackie Noonan by my very good friend and colleague, Willie O'Connor, the pathologist still working in Lexington. And Willie showed, if you look carefully, you can find these microscopic fistulous communications. But they are more important when they become overt. And here in another explant, Diane is showing overt coronary fistulous communications from the cavity of the left ventricle. And again, as we saw last week in the setting of hypoplastic right heart syndrome, the problem comes when the blood goes into the coronary arteries and produces coronary arterial pathology. And in yet another explant prepared by Diane, look across the heart at those horrible ectatic coronary arteries, telling you that overt fistulous communications are a very bad feature in the setting of the hypoplastic left heart syndrome. So the phenotypic variability I've discussed with you, reflecting the timing of the insult that stops the left ventricle from growing, and as yet, we don't know what that insult is, but we can have combined aortic and mitral atresia at the worst end of the spectrum. We can have mitral stenosis, aortic atresia in the middle of the spectrum. And then at the better end of the spectrum, we have combined mitral and aortic stenosis. And now we can take that one step further and we can talk about the hypoplastic left heart complex. As I've already told you, this is a term that was introduced by Christo Chevenkov, still working in Montreal. And Christo maintained, on occasion, the miniaturized aortic and mitral valves were commensurate with the size of the left ventricle, potentially giving you the possibility for functionally biventricular repair. I've already told you that for quite some time I doubted the existence of this lesion, and Christo will remember that we had several discussions as to whether it really exists. But recently, as we've been looking through a series of 2 archives with hypoplastic left heart syndrome, we have found hearts that do, we believe, qualify for description as hypoplastic left heart complex. And we found the same thing in the archive of Birmingham Children's Hospital that I looked at with Bill Chowdhury and Adrian Krushan. So here you see apex-forming right ventricle. You see a thick-walled left ventricle with well-formed mitral and aortic valves, both commensurate in size with the left ventricle. But in this heart, there is a partial fibroelastotic lining, but nonetheless, I would now be happy to include this as an example of the hypoplastic left heart complex. But here is an even nicer example, and there is no question that this is what Christo was talking about when he identified these hearts as forming the so-called complex. Once more, apex-forming right ventricle, well-formed valves, well-formed left ventricle, and this time, no fibroelastosis. So in circumstances like this, I think there is every chance, if you can identify the patients correctly, that you can opt for functionally biventricular repair. And I told you that we've been examining a series of autopsied hearts. I did this together with Diane Spicer. The lead author in this was Elizabeth Stevens, now working in the Mayo Clinic. And we did this in Chicago with Carl Backer, and in the University of Florida with Martin Leiveiss. And of the 119 autopsied hearts, as you see, 36 were at the worst end of the spectrum. About half were in the middle of the spectrum, mitral stenosis, aortic atresia. But we had 26 with combined stenosis, of which 11 we believed qualified for description as the so-called hypoplastic left heart complex. And here is the publication. It's still pending publication in seminars of thoracic and cardiovascular surgery. And this is where we describe our overall findings for hypoplastic left heart syndrome. And so I should also emphasize to you the associated lesions, because thus far I've talked only about the hypoplastic left ventricle. But obviously, if these patients are going to undergo appropriate treatment, it is the rest of the heart that is most important. So that globular left ventricle has an important influence on the right ventricle. It can involve the tricuspid valve, and the tricuspid valve itself can be dysplastic, and that can give problems in the Norwood sequence of operations. But there are other bad prognostic features. The atrial septum can be intact, and that's bad news. That can be mitigated on occasion by venous anomalies, but we should always remember that there is aortic coarctation in at least half of the hearts that we look at in the autopsy room. So the right ventricle is important, and here's a very nice picture of the right ventricle, this time taken from a heart with combined aortic and mitral atresia. You see that the apex of the right ventricle is always, the apex of the right ventricle forms the cardiac apex in this setting. In this instance, there's a well-formed tricuspid valve. It isn't dysplastic, but it can be dysplastic. But what we see, and as we see many times in the setting of combined aortic and mitral atresia, we have the freestanding septomarginal trabeculation, and that can give the impression of a ventricular septum. It obviously isn't the ventricular septum, it is standing free of the ventricular septum, but something to bear in mind when considering right ventricular morphology. But the atrial chambers are equally important. Almost always there is a communication between the atrial chambers, and it's either a propatent foramen or it's a deficiency of the oval fossa. And oftentimes the flap valve is deviated leftwards. But the bad prognostic feature is the integrity of the atrial septum. Although that can be mitigated by fenestrations to the coronary sinus or this strange entity, the levoatrial cardinal vein. But in most instances, as you see here, the oval fossa is patent. The flap valve is deviated to various degrees towards the left, so it is possible to have flow into and out of the left atrium. And even if the atrial septum is intact, on occasion these communications between the coronary sinus and the cavity of the left atrium provide an overflow for that obstructed left atrium. You can also have the overflow provided by this very strange entity, a collateral venous channel that takes its origin from the roof of the left atrium, wends its way through the mediastinum, and terminates in the superior caval vein. And for better or worse, that is called the levoatrial cardinal vein, although it is neither levoatrial nor cardinal vein. But nobody's going to stop talking about it as that. So this is where it is and what it looks like. But this is the problem, an intact atrial septum. And this again is an acquired problem occurring during fetal life. And this very nice example of a fetus prepared by Andrew Cook, you see the integrity of the atrial septum, and look at the thick walls of this left atrium. And the thick myocardium extends onto the pulmonary vein. And then when, in this instance, Andrew did histology of the pulmonary parenchyma, you see that the so-called arterialization extends all the way into the pulmonary veins. In addition to that, we have this cobblestoned appearance of the pulmonary parenchyma. And when Andrew did histology of the pulmonary parenchyma, he found all of this lymphangiectasia. So intact atrial septum with this influence on the pulmonary veins and the lungs themselves, again, a very bad prognostic feature. So finally, let's not forget the arterial pathways. And aortic coarctation is particularly important because that is blocking the blood going back into the aortic arch and feeding the coronary arteries. And we found it in at least half of the hearts we look at in the autopsy room. In most instances, the coarctation lesion is preductal, but it can be paraductal. And as is usually the case with coarctation, as you see in this specimen, the coarctation lesion is associated with the arterial duct. And you can see this sort of fluffy lining here, and you can see how the ductal tissue is lassoing the isthmus of the aorta. The coarctation lesion is ductal tissue. And here's one showing you that the coarctation lesion is, in most instances, preductal. And again, I show you, I've cut it in such a way that you can see the extension of the ductal tissue into the coarctation lesion. And here's one of Diane's. This time, in fact, when we look at the arterial duct, the coarctation lesion is paraductal, but still made of ductal tissue. And here we see yet another problem, because the ductal tissue is now encircling the origin of the subclavian artery. And this is obviously a very important surgical consideration, because if the surgeons are reconstructing the arch, they have to be sure that they remove all of this ductal tissue. If they leave it behind, there's every chance it will become stenotic. So, what have I tried to tell you today as we look at this important subset of individuals with functionally univentricular hearts? It is a heterogeneous morphology that makes up the hypoplastic left heart syndrome, unequivocally, in my opinion, an acquired disease of fetal life. And that in itself is important because as yet we do not have animal models of the hypoplastic left heart syndrome. We have animal models of hypoplasia of the left ventricle, but in the majority of those that have been described to date, they have either had double outlet right ventricle and hypoplastic left ventricle with intact ventricular septum, or they've had atrioventricular septal defect, or they have had transposition. And none of those fit within the definition that now we use for the hypoplastic left heart syndrome. So it can be difficult in the autopsy room to determine when the left ventricle is incapable of supporting the circulation. I know that it can also be difficult in the clinical situation, but in most instances, we don't have that problem. Because when we have fibroelastosis, even in the setting of combined aortic and mitral stenosis with a reasonably sized left ventricle, if it has that fibroelastotic lining, that is very bad news. And in most instances, that points you towards the functionally univentricular repair. We know there are other bad prognostic features, particularly the integrity of the atrial septum, fistulous communications, and that could well point you towards cardiac transplantation as the preferred option. And do not forget aortic coarctation, because if the surgeon is to achieve adequate palliation by the Norwood series of operations, then it is essential in reconstructing the aortic arch to take away all that coarctation, all that ductal tissue. So what I've tried to do is to show you the anatomy that underscores the combinations of lesions we put together to make up the hypoplastic left heart syndrome. Almost all of these are going to be functionally univentricular hearts, but don't forget that very small set that may be amenable to functionally biventricular repair, and those are the ones that Christo Chevenkov christened as the hypoplastic left heart complex.
Thank you, Dr. Anderson. It was an amazing talk. And welcome, Dr. Silverman. We are very happy to have you with us today. We have quite a few questions on the Q&A box. So guys, if you feel like making any question or comment, please type on the Q&A box and Dr. Anderson and Dr. Silverman will be happy to comment and to answer. To start with, Dr. Anderson, I have one question. Where the shunt complex is inserted on this talk?
Indeed, that's a very good question. The Schoen's complex, as you know, was described by a Canadian pediatric cardiologist who was working at the time with Jesse Edwards. So it was first described in the mid-1960s, and I guess it was a little bit after Jackie Noonan had given us the definition of the hypoplastic left heart complex, syndrome rather. Schoen's complex is a combination of one of the features of aortic coarctation, mitral valvar malformations, a subaortic fibrous shelf, and hypoplasia of the left ventricle. So it's sort of a catch-all for things that we wouldn't identify as the hypoplastic left heart syndrome. I think the hypoplastic left heart syndrome is immediately recognizable on the basis of what I've shown you today. I think the hypoplastic left heart syndrome is a diagnosis of infancy. It's found immediately in the first month of life. So you, as clinicians, you all know when patients are going downhill with serious shock, and you know that in the setting of an intact ventricular septum, that's what you'd call the hypoplastic left heart syndrome. Schoen's complex, Schoen's syndrome, I think, is something you see rather later. And I think, again, probably these are acquired diseases, the combination of the diseases, and certainly if there is the subaortic shelf, that is a flow-related phenomenon. So these are things I think you would see at a later stage during childhood, and I would not consider Schoen's complex as being related to hypoplastic left heart syndrome. I think they are two discrete entities. I think that when you see the hypoplastic left ventricle later in life, that is what you would be calling Schoen's complex. I would not use for myself Schoen's complex in the setting of anybody diagnosed within the first weeks of life.
Okay, makes sense. Thank you for that. And I have a second question. Nowadays, we are talking a lot and we are actually doing rehabilitation of this patients with hypoplastic left heart complex. And one of the steps is to remove the fibroelastosis. So what is underneath that fibroelastosis?
Well, I think you're exaggerating when you say that you are doing it. I mean, you might have seen the recent publication in the Journal of Thoracic and Cardiovascular Surgery from the Boston group when they discussed the whole problem underscoring the development of fibroelastosis. And it is the Boston group that has been foremost in seeking, as you say, to rehabilitate the left ventricle. And I think with the best will in the world, their attempts have been less than encouraging. I don't think they've had a great outcome from trying to rehabilitate the left ventricle. One of the problems, of course, is that if you take the fibroelastosis away, it's likely to come back again. We see the other obvious flow-related phenomenon related to the fibroelastosis we've just been discussing, and that is the so-called subaortic, what people call membrane. It is not a membrane, it is a diaphragmatic shelf. It is probably exactly the same tissue that produces the fibroelastotic lining that we see in the setting of hypoplastic left heart syndrome. But in fibro being a problem of fetal life, when we see it in hypoplastic left heart syndrome, as I've shown you, it is uniform around the ventricular cavity, and it is not only a fibroelastotic lining. The Boston group did very nice histologic studies in the paper they recently published in the Journal of Thoracic and Cardiovascular Surgery, and they showed that fibroelastotic lining has roots, and it goes a good distance into the myocardium. And so I think that even if you take away the surface, you've still got what Robert Friedman called the blighted myocardium. I think he was correct that it does, the fibroelastosis does blight the myocardium. I don't think it necessarily had the entirety of the bad prognosis that Robert thought it might have. I think his view was that since in combined aortic and mitral atresia, you don't have that blighting, because although the left ventricle is that much smaller in the setting of mitral atresia, you don't have the fibroelastosis. So Robert's view there was that the myocardium was a little more normal. But I don't think that there is any evidence as yet to show that the results of the Norwood procedure are any better in combined atresia than they are in aortic stenosis and aortic atresia and mitral stenosis. And of course, the problem with the combined atresia is that the ascending aorta is that much smaller, making it a bigger problem for the surgeon, although nowadays the surgeons can get past that. I'm not really up to date on the results of whether the size of the ascending aorta does make a problem, but I think the surgeons can get past it these days. But I think
but it's still a sign of bad prognosis. Less than 2 millimeters of ascending aorta is one of the signs of bad prognosis. So it's better for the patient not to have atresia, but in my point of view, when you have mitral stenosis and aortic atresia, is the most severe case because of the coronary circulation.
But and in that setting, I still think it would, I mean, trying to cut away the fibroelastosis and rehabilitate the left ventricle, I think you're far more likely these days to get a good outcome by going immediately for functionally univentricular repair and accepting that the right ventricle is going to pump the circulation. And nowadays, as you know, things are improving all the time with what we can do down the line. So I think the important thing is to come out at the end of the operation with the patients that's still alive.
This is true. Do you want to comment on that, Dr. Silverman?
Yeah, well, firstly, thank you, Bob, for a spectacular lecture once again and guidance in how to think about these issues. I would just have two comments. The first comment is that Bob has some beautiful specimens which show a gradation of hyperemia within the ventricle. From my point of view, it's the physiology of the coronary flow that determines the perfusion into the various parts of the ventricle. And my late colleague, Dr. Julian Hoffman, had shown that, and we know this, of course, that the heart is perfused from the outside in, and that the gradation of work is exactly in the opposite direction, that when the myocardium contracts, the inside layer of the myocardium has to contract more vigorously than the outside layer, otherwise you have very serious dyskinesis. And so there are three layers that occur within the myocardium, which have been proved with microspheres. There's a layer where there's a lot of work and very little perfusion, and that's the endocardium. Then there's a layer in the middle where the perfusion and the work are equivalent. And then there's a layer on the outside where the amount of work is less and the perfusion is more. And so that leads to the development of endocardial fibroelastosis. And I think that's a very important issue, because it can be seen if you cut across the section of the myocardium, and Professor Anderson has got some wonderful examples of this particular entity. And I think once endocardial fibroelastosis is developed from a physiological point of view, it actually impedes everything in terms of the circulation, because when you have a thick layer on the endocardium, the ventricle cannot fill. And so the development of ongoing hyperplasia gets worse the more the endocardial fibroelastosis exists. And that's kind of prevents the ventricle from filling, and also with a thick layer of fibrous tissue, that also prevents the ventricle from contracting. So this is part of the developmental process that occurs. And of course, again, the people from Boston have made this their own bailiwick. They have shown that the development of hyperplasia can occur around about between 16 and 22 weeks. And, you know, if you're going to try and do an intervention for critical aortic stenosis in the fetus that you see developing in hypoplastic left heart syndrome, you have to get it at about a reasonable time where you can prevent this from occurring. So that's very important in terms of the development of this condition. The other thing I would like to say in support of Professor Anderson is this lever atrial cardinal vein business. And we recently published a paper where a patient had a left superior vena cava to coronary sinus connection and a lever atrial cardinal vein. And that I'd actually communicated with Dr. Anderson about this. But the lever atrial cardinal vein, the coronary left superior vena cava to coronary sinus, must claim that as an embryonic reality. So the lever atrial cardinal vein cannot be a part of this that we call a lever atrial cardinal vein. And the challenge to Bob, of course, is, Bob, what would you call this particular structure? My colleague Paul Weinberg has pointed out that the lever atrial cardinal vein is not like the standard type 1 total anomalous pulmonary venous return, which goes to a left superior vena cava, but that rather it comes from the origin of the left pulmonary veins and not from the central part as you would expect. So, Bob, the question is, what do you want to call the structure? Being a nomenclaturist.
It's simply a collateral channel, a collateral collateral pulmonary to systemic venous channel. I think that's the easiest way, but nobody's going to stop calling it the lever atrial cardinal vein, so we may as well stick with that. And just
Okay.
It's neither lever atrial.
Well, I mean, you know, I think you've never actually flinched at renaming structures. For example, an interventricular communication is not a VSD.
Indeed.
So,
I think that does have rather more functional significance because, as you know, you cannot close the interventricular communication, whereas surgeons spend all their time closing VSDs. So. That's
true. Now, the one other thing about lever atrial cardinal vein is that we had reported a patient who was 12 years old with a hypoplastic left heart syndrome, which was previously reported at 6 years of age from a center on the east coast of the United States as a longest survivor of hypoplastic left heart syndrome without any surgery. And this child unfortunately died from pulmonary vascular disease. But when there's something like a patent ductus which persists in hypoplastic left heart syndrome or lever atrial cardinal vein with some obstruction, the pulmonary artery pressure will not fall and the ductus remains open for a length of time. And eventually can give you long-term survival. And all of us have heard of patients in the old days. I remember Hunter describing this, that said that a patient would die and they sent the patient home, and 3 months later, the patient was still alive at home with multiple oxygen cylinders in the front yard. So I think that although it's generally considered a lethal condition, there are isolated cases with hypoplastic left heart syndrome that survive for long periods of time. That's all I have to say.
Indeed. Good points. I think your point about the coronary circulation is particularly important. And from what you're saying, I mean, it reinforces what I was saying in a way off the top of my head, that the fibroelastosis is much more than just a surface lining.
Oh, absolutely. And as you've shown in your pictures, it can extend to greater or lesser degrees within the myocardium.
Yeah.
It also almost always invariably involves the papillary muscles.
Yeah.
And I think that also prevents functionality within fetal circulation as well.
This is amazing. And even still talking about the fibrinostosis, a colleague from Saudi Arabia, Salim Ahmad, is saying that he has a patient, mitral stenosis, aortic stenosis, and had a restrictive atrial communication. And he has the echogenic aspect of fibrinostosis up to the pulmonary veins. And his question is that even after the palliation, if this alteration is going to continue there or it's going to continue to develop.
He will know the answer.
Yes.
I don't think we can, I cannot predict that. I mean, it will be interesting to know what happens.
Yeah.
This is interesting. And we have another question. Hannah is asking if you could please reinforce the difference between hypoplastic left heart syndrome and the hypoplastic left heart complex.
Well, one of the reasons that I disliked the term complex, because to my mind, it is part of the hypoplastic left heart syndrome. So the reason, as I said throughout my talk, for quite some time, I did not think it existed as an entity, but as we started looking at the archives, I mentioned two particular studies that I was involved with. The one where Bill Chowdhury from Newcastle came down to the Birmingham archive, and Adrian Cruchan is the archivist of the Birmingham archive. So Adrian and Bill and I looked through the Birmingham archive, which in fact Adrian has reconstituted in amazing fashion, and there are now 2,000 hearts in the Birmingham archive. And Adrian went very carefully through the Birmingham archive, and of the hearts that had been categorized previously by the pathologists, so they were entered into the archive as having hypoplastic left heart syndrome, it became obvious to us that amongst those hearts, and off the top of my head, I think there are about 120 hearts, 11, as I recall, in the Birmingham archive, had been diagnosed previously by their pathologists as having the entity which we would now, which Christo called hypoplastic left heart complex. And then when we looked through the additional archives together with Diane Spicer and Elizabeth Stevens, Diane looked at the hearts in the Florida archive, particularly the Van Meerop archive, and Elizabeth looked at the Lurie archive. And again, in both of those archives, there were hearts that the pathologists making the diagnosis had called hypoplastic left heart syndrome. But we now categorize them as being the same thing as what Christo called hypoplastic left heart complex, namely, the left ventricle was unequivocally small, but the mitral valve and the aortic valve were commensurate in size with the left ventricle. And one of the features that I had discussed previously with Christo as to why maybe we shouldn't be calling it the hypoplastic left heart complex is that we know that, for example, in total anomalous pulmonary venous connection, the left ventricle can be very small. You put the blood back into the left atrium after you correct total anomalous pulmonary venous connection, and the left ventricle takes over. And Christo showed that that could happen in these instances. So there's no question that in the most appropriate cases, instances where previously the pathologists had diagnosed these individuals as having hypoplastic left heart syndrome, this was long before the days of the Norwood procedure, long before we had any treatment for these children at all. There is the chance now that in a very small proportion of these cases that in the past would have been diagnosed as hypoplastic left heart syndrome, they can go forward to biventricular repair. But I think it's very, very much in the minority. And I think you would need to be pretty sure that you were dealing with an entity that could justify biventricular repair before you opt for that mode of treatment. Norman, I don't know whether you have anything to add on that basis. You've been around for a long time. Have you seen anything that you would have called the hypoplastic left heart complex?
You know, I can't actually recall patients that I've seen that have the hypoplastic left heart complex, but perhaps I've miscategorized them as hypoplastic left heart syndromes. The point that you make about the total veins, of course, is very important. I associated with Dr. Colin Poon on this, where we looked just at looking at the model of the left ventricle and changing the convexity from the concavity of the ventricular septum in the preoperative and postoperative totally anomalous pulmonary venous return, and made a calculation and found that just by changing the configuration of the ventricular septum, the ventricular volume increased remarkably. And of course, the same issue occurs in the hypoplastic left heart syndrome complex, whichever ones you look, that the right ventricle then takes over as the dominant ventricle, and its configuration changes during development from a concavo convex right ventricle to a spherical or a conical right ventricle, and that further changes the position of the ventricular septum and makes the left ventricle look small. And this is certainly the case in hypoplastic left heart syndrome. Our model was not correct by just looking at ventricular volumes, because we failed to understand that when there's an increased volume in the left ventricle, the length of the left ventricle changes. So we didn't take into account that when you fill the left ventricle up, it elongates as well. And that was the difference between the calculation of a small left ventricular volume preoperatively and a normal ventricular volume postoperatively. And you can see this immediately on coming off bypass if you're doing transesophageal echoes in total anomalous pulmonary venous return. The ventricle is small preoperatively, we're pre-bypass, and when you go by post-bypass, immediately it's a normal left ventricle, and the right ventricle assumes its standard shape.
Thank you very much for the comment, Dr. Silverman. We have one last question. Guillermo Lopez is asking is there a clear association between Hirschsprung's disease and hypoplastic left heart syndrome?
If there is, it hasn't come to me, but I tend only to see the hearts that are in the archives, and oftentimes we don't go into the history, but I am unaware of any association. I also saw there was one question there, Grace, where someone was asking about spongy myocardium. Spongy myocardium is one of the worst terms ever invented, because in reality, what people call spongy myocardium is excessive trabeculation. It is not the same thing as non-compaction. You should not be calling it non-compaction. So I think spongy myocardium should be banned. And there is no association whatsoever between the thickening of the wall we see in the setting of hypoplastic left heart syndrome and spongy myocardium.
Again, one amazing session, and we are very happy to have you, Dr. Anderson. Thank you for your time.
The interesting thing is next week, we're going to be talking about double inlet left ventricle. And in years gone by, probably before most of the people who are listening today were even involved, it was double inlet left ventricle. It was all the controversial lesions. So it will be interesting next week to talk about double inlet ventricles again. So hopefully everybody will be with us again next week and then we have two more. We're going to talk about double inlet ventricle next week, and then atrioventricular valvar atresia, which Norman is particularly interested in. He's been asking me about whether, you recall last week, he asked me whether we could have absent left atrioventricular connection on the left side. And so we will be talking about that. So we hope to see everybody next week.
I'll be here.